Our next speaker is Dr. Ibrahim Al Homood. He's a consultant rheumatologist, director of Rheumatology Fellowship Program, King Fahad Medical City, Riyadh. He's the director of Internal Medicine Training Program, member of Saudi Scientific Council of Internal Medicine, member of Rheumatology Fellowship Scientific Committee, and member of Euro-Lupus Society. Dr. Ibrahim will talk in the next 20 minutes cardiac involvement in systemic lupus erythematosus. Welcome, Dr. Ibrahim.
Thank you very much, Chairperson, for this introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like, before starting, to thank the organizing and scientific committee for inviting me to talk about the cardiac involvement in lupus patients. And I have been given a challenge that to reduce the time of this talk as much as I could. So we'll try to go quickly, illustrating the most important messages from the cardiac involvement in lupus patients. First of all, the cardiovascular diseases are the most common cause of morbidity and mortality in lupus patients, and the overall prevalence is 6 to 10%. The incidence of new coronary artery events is 1.5%. And looking to these numbers, that means the lupus patients are 5 to 10 times more likely to experience coronary artery events as compared to general population. And I would spend most of my talk about the coronary artery events, that's what I think we should pay attention to these entities. Now the SLE have two higher number of atherosclerotic plaques in the carotid and femoral artery as compared to what has been reported in rheumatoid arthritis and diabetes. And I mention this statement intentionally because if you look to the heart, if you look to the American Heart Association in their lipid guidelines, they mention rheumatoid arthritis as an example of chronic inflammatory disease. All of us concerned about diabetes, but SLE, it's even higher than rheumatoid arthritis and diabetes, a risk for atherosclerosis. Now, lupus nephritis, as Prof. Sami said earlier, it's not uncommon in our society, in our patients, and in our cohorts. In our lupus cohort, in KFMC, we have around 30 to 35% of patients, they develop lupus nephritis. And lupus nephritis is considered one of the risk factors for atherosclerosis. As you see here, the lupus nephritis is associated with twice evidence of carotid atherosclerotic plaques as compared to the lupus patient without nephritis. So the coronary artery disease are a major causes of death in lupus patients, particularly those with late onset or patients with long-standing SLE. And then we should think about the risk factors for the atherosclerosis. If you look to the traditional risk factor, it does not explain this high risk in lupus patients. And this is so obvious because these risk factors, including male, old age group, more than 60, and looking to our lupus patients, usually are female, and usually they are young in the childbearing age. So there has to be other risk factor for the coronary artery diseases. It might be explained by some genetic variation, but this is not the whole story. It's mainly related to the endothelial dysfunction. And it has been demonstrated the endothelial dysfunction is increased in lupus, and it's correlated with the high coronary calcium score. So patients with lupus, they have profound imbalance between the endothelial cell damage and repair, which promote the development for atherosclerosis. So one of the risk factors, or they explain this increment in the risk of atherosclerosis, is the dysregulation of the innate immune response in lupus patients. Now we know the lupus patients, some of them, they have high type 1 interferon signature. Those with this high type 1 interferon signature, they are more prone to have decreased endothelial function. And they are at higher risk for atherosclerosis, even if they have stable disease. And there are pro-inflammatory neutrophils, which called LDG, the low-density granulocyte, and this will enhance formation of NETs, which is neutrophil extracellular traps. Now, I don't think the printer is working, but anyway, if you look to the interferon gamma, when it's high, it will inhibit the expression of the endothelial nitric oxide synthetase, which is very important for nitric oxide. And this will promote the endothelial dysfunction. Not only that, those with high interferon signature, they will have impaired insulin resistance. And then they will have abnormal glucose metabolism and hepatic inflammation. As you see here, net will increase the vascular leakage and more endothelial damage. It's also the autoantibodies play a role in the atherosclerosis. We know the lupus patient, they have IgG anti-oxidized LDL antibodies, which is significantly elevated in lupus patients. Antiphospholipid antibodies increased, as all you know, the thrombosis both for the arterial and venous. And the antiphospholipid antibody is not only increase the thrombosis, but also it's bind to the oxidized LDL, forming the immune complex that activate the macrophage, more formation of foam cells, more production of pro-inflammatory cytokines, more endothelial damage. And as you see here, the oxidized LDL immune complex will trigger many inflammatory cells, dendritic cells, more production of IL-1 beta, more activation for T cells, and then more pro-inflammatory cytokines that result in endothelial dysfunction. It's also related to the disease activity. And it has been shown that if you have a patient with active disease, if the 6-point increment in SLEDAI score will increase 5% the risk of coronary artery diseases over 2 years. Lupus nephritis, again, it's appearing is a very, it carries a high risk for the atherosclerosis. And more interesting to me that he found the neurolupus is considered as a predictor for the coronary artery diseases, and particularly the psychosis and seizure, suggesting the neurolupus could be a risk factor for accelerated atherosclerosis in lupus patients. So antiphospholipid antibody, it's presented in 30 to 40% of patients with lupus. As we know, it carries a risk for thrombotic events, both arterial and venous, and valvular diseases. Now, what we did, we published a study that we screened our patients who are asymptomatic, who are in clinical remission. We did the echocardiogram to screen them for any structural heart disease. And we found that those who are having positive anti-double-strand DNA, they have valvular abnormalities, both mitral and tricuspid valves. It's not only that, those with positive antiphospholipid antibodies are more risky to have structural heart disease and valvular abnormalities. And then we conclude at the end, asymptomatic lupus patients who are clinically inactive but serologically active, which all we know that there are an entity which called clinically quiescent, serologically active, and vice versa. Or those with positive antiphospholipid antibodies should be screened by echocardiogram for evidence of structural cardiac abnormalities. Now, corticosteroid therapy, we all here seeing patients with lupus, and we all start our patient on steroid. We know that steroid, it's a cornerstone for treatment of patients with active clinical manifestations. But we all again know that the steroid has numerous metabolic side effects, blood glucose, lipids, and the others. So, I think Michel Bitry showed that if you started the patient on 30 milligram corticosteroid, you increased 60% risk over 2 years, the cardiovascular, than lupus patient with the same disease activity, with the same traditional risk factor. And this is very clear, the role of steroid in increase the cardiovascular events. So we need all to monitor the steroid, and we should use steroid-sparing agents whenever we are managing lupus patients. Now, a very common dilemma, what is the role of steroid? Is it related to the dose? Is it related to the current dose at the time of the event? Or is it related to the duration of treatments? There are several trials that support duration is more important. However, there are trials again that support the cumulative doses of steroid. So what's about hydroxychloroquine and coronary artery disease? Hydroxychloroquine, as mentioned by the speakers earlier, it has a favorable effect on the lipid and the glycemic control. It has antiplatelet, so it would reduce the risk of thrombovascular events. And it's not only that, it has been shown that it's associated with low progression of carotid plaques and aortic stiffness. So hydroxychloroquine should be our friend, should be a cornerstone for treatment of lupus patients, unless it's contraindicated. When we think about the other modalities, when we are managing SLE patients, there are no clear clinical data about the immunosuppressive therapy. Yes, there are some experimental data, but it's not yet approved clinically. Now, the interesting is the BAFF inhibitor. It has been shown it prevents ABS in lupus-prone mice. So it might have a beneficial in preventing thrombosis in patients with SLE. Now, I would like to draw your attention to vitamin D and coronary artery disease. Please remember there are no enough data and the evidence is lacking behind giving the patient vitamin D to reduce the atherosclerosis. Now we know patients with lupus are more risky to have dyslipidemia. They have elevated total cholesterol, triglyceride, LDL, decreased LDL. Not only decreased LDL, they have altered HDL function. And if you have such patients, statin is a very good choice. It has been shown that it reduced the mortality in cardiovascular disease in lupus patients with hyperlipidemia. And why I'm saying with hyperlipidemia, because when we think about statin and atherosclerosis, statin, it has been shown it reduced many pro-inflammatory cytokines and chemokines, such as IL-6, 8, TNF-alpha, MCP1, and it has been shown in Chinese population over a small population over a short term, over 8 weeks, that it reduced LDL, CRB, and beta-selectin and thrombomodulin. When atorvastatin given at dose of 20 milligram, it reduced the arterial stiffness in lupus patient female. When it's given to 40 milligram per day, it stabilized the coronary artery calcium score. But always remember, these trials are either small in number, the population, or done over the short time duration. So now why we said when you have patients with dyslipidemia, because this questions come in my mind when I prepared my talk. Can we use statin as a preventive medication for atherosclerosis? And the answer, unfortunately, is disappointing. Now, Petrie and her colleague, they showed that over 2 years, double-blinded study, which is named LAPS, the Lupus Atherosclerosis Prevention Study, was unfortunately disappointing. Not only at the clinical event, even at the level of the lab. So we might say what has been shown with statin in non-lupus patients is not probably true till today in lupus patients. So how would you screen the patient for coronary artery disease? The most commonly used is the carotid ultrasound, where we could use the intima media thickness ratio. But always remember, 40% of our patients, they have carotid plaques. And keeping in our mind the progression of this carotid plaques is more frequent as compared to non-lupus patients. So when you have a patient with lupus, I encouraged me and you is to check the other atherosclerotic risk factor in our clinic. We should check the diabetes. And if your patient is diabetes, keep your goal, HbA1c is less than 7%. Check the lipid every 6 months. Keep these numbers as your goal. I know the new guidelines, they concentrate more on the percentage of reduction, but lupus patients should be considered as a very high risk for atherosclerosis. We should discuss with our patient the smoking cessation. And keeping in mind, stop smoking is not to reduce the risk of atherosclerosis, but also to improve the response to hydroxychloroquine. we should check their body weight. And we should encourage all of them to do the exercise and keep the ideal body weight. Now, blood pressure should be checked on each visit. An antihypertensive medication should be initiated without hesitance when your blood pressure is more than 130/80. And a recent survey that just published from Italy, they found more than 52% of the rheumatologists, they don't target 130, they target 140 and above. So we should pay attention to the blood pressure. We should target 130/80 or even lower in the presence of proteinuria. Now, because of time, I wouldn't go through the other clinical feature, but quickly touching them, pericarditis is most common cardiac manifestation. A quarter of our patients, they will develop pericarditis throughout their time, and we should do the ECG, echocardiogram. Pericardial biopsy is not required and shouldn't be done to establish the diagnosis. Now, should we do ANA in patients with first episodes pericarditis, female? I think we should discourage this behavior. You should not order the ANA for a patient with first episodes pericarditis. The most common cause is viral, and ANA also could be positive in patients with viral infection. The treatment, as all you know, is the corticosteroid and optimizing the DMARDs therapy. Which one data are contradicting? There are some trials supporting azathioprine. MMF has been used also with good result. Now, myocarditis, it's rare. So we shouldn't pay a lot and thinking about myocarditis when you have patients. Now, it's most likely due to the immune complex deposition. It can present with heart failure, it can present such myopericarditis. You need to do the echocardiogram. You will find a global hypokinesia without evidence of coronary artery disease.
2 minutes.
And because of the time, the valvular disease, just one thing, when you have a patient with valvular disease, you should always check the antiphospholipid antibodies. When you refer the patient to the surgery, always think about the mortality risk of valve replacement. Lupus, it's high, and probably the transthoracic valve replacement is safer in lupus patients. So in summary, cardiovascular is still major cause of death in our patients. And SLE should be considered per se as a strong independent risk factor for development of coronary artery disease particular. Just to draw your attention, there are no standardization for the methods for imaging of assessment for atherosclerosis in lupus patients. Inflammation, we should always think about it, and it's play a major role in driving the premature atherosclerosis. Longer duration of steroid increase the risk for development of the coronary artery disease. This is the risk factor that we should all think about it when we handle the patient with lupus. We should always think about the traditional risk factor, inflammatory risk factor, lupus-related risk factors. And we should always think about the traditional and non-traditional risk factor whenever we are managing the patient. You should not bother yourself about the biomarkers because most of it at the level of experimental studies nowadays. Always please think about corticosteroid. Try to minimize it as much as you could. Plaquenil should be a cornerstone in all lupus patients unless it's contraindicated. So rheumatologists are frequently burdened with details of lupus itself. We tend to ignore or forget evaluation of the cardiovascular risk factor. And it has been demonstrated in several surveys that it's suboptimal. I think we should plan to evaluate our patient. We should establish the prevention counseling program. We should establish the protocol in our clinic in order to overcome the busy clinic by remembering these important factors. Now, we should always think about the patient perceptions. We are rheumatologists. They think that we are concerned more about the musculoskeletal manifestations, lupus nephritis, and other immune disease. But they tend to forget to tell you about their risk for their cardiovascular disease. And this is our duty that we should ask them, evaluate them, treat them as early as possible. And thank you very much.
Thank you, Dr. Ibrahim, and I would like to thank all speakers and welcome them to the podium. So we'll have 2 questions and then we'll go for the lunch.
Assalamu alaikum. I have a question for Professor Cervera. In your center, do you have any data about the use of certezilumab in obstetric antiphospholipid, whether as prior to pregnancy or after establishing pregnancy?
Certolizumab?
Yes.
Well, we have not personal experience, but I have to tell you that there are studies now going on the use of anti-TNF, especially certolizumab, in patients with refractory obstetric antiphospholipid syndrome, because it has been shown that TNF plays a role in this obstetric antiphospholipid syndrome. And apparently, and I have some, let's say, pre-published information, it works. Mm-hmm. So let's see what happens, but could be this for refractory obstetric antiphospholipid syndrome could be an option.
How about any personal experience with IVIG in obstetric antiphospholipid?
We have in this case, we have one case with 10 recurrent abortions that finally with intravenous immunoglobulins managed to get a baby. And, but results are probably just case reports and personal experience. When there is a study, there is a couple of studies that sum up this information, and at the end of the day, they couldn't reinforce the option of intravenous immunoglobulins as a standard therapy for these recurrent abortions. So what we believe is that in these cases where certainly you don't have more options, you can try this. But first, I would first option would be aspirin or aspirin plus low-dose molecular weight heparin at prophylactic dose, unless the patient was anticoagulated for thrombosis, that it's a full anticoagulant dose. An additional option, second option, if it doesn't work, could be to add also hydroxychloroquine and or low-dose steroids. Low-dose steroids, that was the treatment at the beginning of the story of obstetric antiphospholipid syndrome. Then it was refused because of side effects, but nowadays we know that it probably can prevent this early fetal losses. So this could be an additional option. And then if this fails, then you have options such as intravenous immunoglobulin, such maybe certolizumab. Even plasma exchange has been tested in some patients, but I think that the first options would be, if there is a failure of the standard therapy, hydroxychloroquine and low-dose steroids.
Appreciate it. Another question quickly for Dr.
That's enough for the sake
All right.
of the time.
Thank you.
Okay.
If you have any other filing question, you can ask.
Okay, thank you all for your attention. Thank you to our speakers. And just announcement from the organizing committee, the next session will be at 1:15. It will be by Prof. Suzanne. Thank you.